Thank you very much, and I'll hand it over to Kokila now. Thanks, Kokila.
Thank you, Alp. Welcome, everybody. It gives me great pleasure to introduce Professor Chris Bode. I must say, his bio had made Professor Ame speechless, so he couldn't introduce him today. So I've decided to do it on his behalf. I first met Professor Chris Bode on an e-platform where we shared a chapter together for the Africa book. And ever since then, I've been amazed by the progress he's made for children in Africa. He qualified from the University of Ife in Nigeria in 1980, and he's the fellow of the West African College of Surgeons, the Medical College in Surgery in Nigeria, and also the Academy of Medicine as a founding member in Nigeria. He's presently the Professor of Surgery at University of Lagos, and he's the Chief Medical Director of Lagos University. He's the former Secretary General of the West African College of Surgeons, and his academic interest is in complex perineal reconstruction in males and complex esophageal atresia work. He's president-elect of the Pan-African Association of Surgeons, and recently in Nigeria, he was named one of the 20 health heroes for his country. His great interest is African masks and gardening. So I'd like to welcome Professor Chris Bode, and we look forward to his talk.
Thank you. Thank you. Thank you. Please, my best wishes and regards to Professor Ame, my great mentor and friend. Distinguished ladies and gentlemen, colleagues, it gives me a great pleasure to be with you this afternoon and to share with you our experience at the Lagos University Teaching Hospital on the management challenges, outcome, and some lessons learned on the COVID-19 pandemic outbreak, which is worldwide now. So we have introduction. The duty of care for doctors and indeed healthcare workers is a topic of much debate because in our line of work, we are already exposed to all sorts of risks. But when epidemics and pandemics come, are we ethically bound to die on the field or should we flee for our lives? Where should we draw the line? And that has always been an issue. The Canadian Medical Association in 1922 gave the opinion that doctors should labor for the elevation of pain during epidemics and disasters, even at the risk of their own lives. That opinion did not stand the test of time as it was expunged 4 years later. The same thing with the American Medical Association, which also gave the opinion that doctors should face, in the face of great danger, face unusual risks to their own safety while rendering services to mankind. It also disappeared from the statute books until 9/11 when it resurfaced. Because to require doctors and hospital workers to face such uncommon danger will be tantamount to asking them to be supreme Samaritans. And that people do it. It's either they do it for glory or for a good pay, or in very few exceptional cases for altruism. In Nigeria, that issue is not yet been much discussed. It can arguably be mentioned, be said to be inchoate. It's still in its infancy. Let me welcome you to the city of Lagos, a mega city of 23 million persons. That's our skyline, but we do everything big in Nigeria. That's how we live. We are rioters, we are tumultuous, and with this kind of scenario, you can imagine how we felt in January this year when the COVID-19 broke out everywhere and people were dying in hundreds of thousands in China, in thousands in America, in Italy, and in the UK. So no wonder that predictions of COVID-19 in Africa had an apocalyptic outlook. We thought we will all be dying on the streets. But because we are very poor in infrastructure and the capacity, we thought that we should start planning early. And that was what we did at the federal level, at the state level, at the provincial level, and at the hospital level. We were assembling, by January, February, we started assembling volunteers, and we commenced training in infection prevention and control, and what to do and what not to do in infectious disease scenarios. We identified an isolation block of 120 beds, and we interfaced with government, and we sourced for beds, PPE, consumables, and we put a structure down. We were told to be operating under the aegis of the Lagos state government. That's a picture of my team there. We built various teams, infectious disease specialists, emergency groups, physicians, obstetricians and nurses, microbiologists, the labs, kitchen staff, operation room staff, and all these were under the aegis of the hospital management. In February, late February this year, the index case landed in Lagos on 27th of February, and we knew we were in for it. While we were ramping up capacity, in sometime mid-March, a plane load of merrymakers infected all arrived from London after an 80th birthday bash, and they went to extensively distribute this virus all over the city of Lagos. We were in trouble, we knew that, but the Lagos state government had an isolation center and was planning to build 4 others. So very soon the 120-bed state isolation center in Yaba filled up, and it wasn't raining, it was pouring. Other 4 centers that were planned, yes, they were not yet operational. This was one of them, tent-like structures built in a stadium and stuff like that. We at the Lagos University Teaching Hospital were training, we were appealing to our people, we got hotel accommodation ready, we made arrangements for feeding, oxygen, backup staff, emotional and psychosocial support. But there was a groundswell of opposition to us welcoming COVID-19 patients in our hospital. Therefore, we were addressing those challenges. But as the unions continued to raise concern, the voices of the naysayers became very loud. And at a point, I had to make an appeal.
If we do not confront COVID-19 squarely now, it will start looking for us in our homes, God forbid.
And how prophetic those words were. People accepted, and with trepidation, we started. This is the chain of command. Our head of state set up a presidential task force that could disburse materials and advise, and took decisions with the stamp of the head of state. The state governors were the linchpin in the whole exercise, and a lot of donations, a lot of money went to them, amounting to hundreds of millions of dollars. The Nigerian CDC also was free to assist whomsoever they chose. So you could see those lines, they were not equal lines. We at the federal hospitals got shafted because the state governors were only channeling funds and materials to their own hospitals. The private sector set up their own standalone isolation center, and NCDC was the only bedrock that was steadily giving us whatever we needed once we shouted and shouted. On the 7th of April, because all facilities in Lagos were full, we had to jump into the infested water and admitted our first patient in Luth. We had admitted 4 patients that day, and then things started moving. That's the facility where we've been admitting. It's a 4-story building, 120 beds, but the top floor is used by our COVID warriors, and the other 3 wards are used. That's the interior of the place. And we have 106 all-volunteer staff. They were housed in neighborhood hotels, and they worked in shifts from from the top floor of the isolation center. And these gallant chaps were denied access to their families for weeks at a time. Let me say that with a population of 23 million persons in Lagos megacity, there are only 2 teaching hospitals. It was only our hospital that was willing to accept and treat COVID-19 patients, while the other hospital family shut down its gates. There was palpable tension in the hospital, and all services were scaled down for non-COVID patients, and we had less than 100 undischargeable patients on admission. Once a frontline officer, properly socially distanced from everybody that came to the hospital, saw any patient, they will administer the COVID score on them. And if they should score high, then they invited a properly suited members of the COVID squad who will test the patient appropriately and admit if positive. I must also mention that COVID-19 cases requiring multidisciplinary team management, where the patients mostly referred to Luth by all centers, from government centers, from other hospitals, all that. And such patients had things like hypertension, diabetes mellitus, cardiac conditions, respiratory, pregnant women, COVID positive who needed cesarean section, renal, and all sorts of cancers and stuff like that. And within the last 6 months, we have treated and tested free of charge 561 patients and discharged 501 patients. We recorded 56 patients and deaths, and we have done over 7,000 COVID-19 tests. This was the graph for Nigeria, not just for Lagos. You could see we peaked in July, and then the state government thereafter asked us to allow COVID-19 patients who are asymptomatic or mildly or moderately symptomatic to be treated at home on self-isolation rather than admit them. So that was when the graph dropped. This is what has been happening in the world, with America still recording very high rates. Like I said, our infection admission rate, everything peaked in July at the height of the community spread, and home care was accepted thereafter because isolation centers could no longer cope with the cases. These isolation centers built by the state government, not in our hospital, on its own isolation center grounds, came way after, later in August. It will be there for future use, or if there should be any further waves of COVID-19 or other diseases. We had several challenges. Shortage of PPE. We had shortage of ventilators, drugs, especially at the peak when we had 93 patients on admission. Full capacity was a stress, and we had to call on state government, federal government with bureaucratic delays, but the NCDC was always there whenever we needed. There was low morale, which ensued when the state government gave almost $2,000 extra money to its own workers, while our own workers treating patients from the same state, from the same city, felt cheated because they were not giving anything. They almost down tools until I had to give them some money from the hospital, and later on, the federal government suitably rewarded them as well. We had some workers, a few workers who developed post-traumatic stress disorder, and emotional and psychosocial support needs were rampant. Like I mentioned earlier, there was a dislocation between resource allocation and needs. An emergency center operation center was decimated by COVID-19. This was the nerve center of the state's planning. When it was decimated, there was nobody to start taking certain critical decisions. COVID-19 outbreak among loose staff. While none of our workers, 106 workers treating COVID-19 patients in Luth suffered any, none contracted COVID-19 from the patients they were treating, about 80 Luth patients contracted COVID-19 from community spread. The cost of face masks spiked 2,000%, and ventilators, excuse me, that when there were 3 ventilators available for purchase in Lagos, an oil company quickly snapped up 2 of them, and the 3rd one was bought by a very rich Nigerian who put it in his house because in case he contracted COVID-19. There were transportation difficulties because public transport system were locked down, and policemen frequently harassed our health workers going and coming back from work, or their husbands who came to pick them. Collateral damage occurred with patients, non-COVID patients, who suffered denial or delay because of the palpable fear in the land. And our own gallant warriors treating COVID-19 patients were stigmatized by their colleagues. Hey, don't come near me, please. Don't come here. You are already infected. The emotional and psychosocial support group for the state of Lagos started in Luth with 25 of our workers who joined our staff to break bad news to positive patients, and they counseled patients for admission. And sometimes when patients disrupted their ongoing therapy, they had to be called in. They also supported our staff greatly and supported certain departments who refused to reopen after COVID was not going away. I must thank Messrs. Airtel of Nigeria, who provided 81 telephone lines and funded these lines for the duration of COVID-19. About 10,000 calls were made, and 78% of the calls were through. And about 26% could not be reached because they either gave false telephone numbers or false addresses, and another 227 cases disputed their results. That team worked very greatly. We in Luth also trained personnel for 4 other institutions on infection control and how to set up their own isolation centers, and we assisted the state government in setting up their own center as well. Like I said, none of our staff treating COVID-19 patients contracted it. This is in contradistinction to what we were seeing on TV from America and China and other places. Our staff did not contract it from patients. We think the training they had went a long way to ameliorate this, because 80 non-volunteers contracted COVID because they were moonlighting in other institutions outside without taking adequate precautions. We contact traced 250 persons from these 80 patients, and training is essential to prevent that. From this graph, you can see that doctors considered about 60% of the staff who contracted COVID from outside. This was our pattern of bed occupancy in Luth, and our OBGYN team was coaxed. We coaxed them to perform the first cesarean section, even against their own wishes, because their department had already been decimated by community infection before. But we performed a total of 11 cesarean sections, and we had 12 babies. All mothers and babies were successfully discharged home. Comorbidities, hypertension, 33%, diabetes mellitus is 16%, chronic kidney disease, cancer, and all that constituted 60% of all, they were seen in 60% of all patients. And the outcome, overall, 85% survived and 10% died. This, even if it looked high, was because we had an unfair number of patients with a lot of comorbidities that couldn't be treated in other places. Some patients discharged themselves, some were transferred out to other places on their own request. Diabetes mellitus was statistically significantly associated with high mortality. When there was, with multiple comorbidities, the chances of dying was 84.4%, especially when they also presented late or they were also elderly. Severity of admission. Patients who came in elderly, critically ill, gasping with very poor oxygen saturation, and who had several other comorbidities had 75% chances of dying. I will therefore summarize by saying that late admission in critical condition and with multiple comorbidities were significantly associated with high mortality in our patients. And that in spite of constraints, several constraints, the LUTH team went beyond the duty of care to salvage majority of challenging patients admitted into our hospital. The pandemic also unlocked many opportunities for public-private collaborations, and quite a number of bodies who couldn't travel out of Nigeria during the lockdown realized that they would need to empower public hospitals which had been long neglected in case such a thing occurred again. And psychosocial and emotional support, contact tracing, and the observation of universal precautions were crucial to success in our care. There is need for robust research into the reasons why we saw only mild to moderate outbreaks in Nigeria. Many Nigerians don't believe that there is anything called COVID till today. They are refusing to wear masks and they are still alive and well. Rather than the doomsday COVID-19 predictions that we had before the onset of this disease. If you ask me what will I do if I had to do it again, I will start preparations very early. I will set forth at dawn, and I will inspire a great team because without that kind of team, not much could have been done. You won't believe that I'll stay back in Africa because we seem to be doing better than other regions. And but this time around, I will let the government put its money where its mouth is. And every day, I will tell my team members, we must go beyond the duty of care because that's what we are supposed to be doing. Yes, we must. I thank you very much for listening. Thank you.
Thank you, Professor Bout, for this very inspiring talk and for these inspiring words. We really congratulate you on your task of leading the LUTH team and also leading the country in understanding where it matters the most, that we as health professionals need to be there rather than run in the other direction. And also you mentioned that, we should stay in Africa because that's where it was safest. I remember very clearly when the virus started in China, everybody was worried that, oh my God, what's going to happen when it reaches Africa? But I think Africa has proven itself to the world that we in Africa concentrated on primary health care and looked after people in the community rather than in the high-income countries where they concentrated in tertiary centers and ventilators. So thank you very much for your talk. And as this is one of the base talk, there won't be any questions for now, but maybe at the end in the discussions. Thank you very much once more.
Thank you very much, Kokila. Our next session is chaired by Professor Bankole and Professor Nia Dejai. The microphones are unmuted. I'll hand it over to Nia.
Okay. Good evening, good afternoon, good morning, colleagues from around the world. Thank you again to Professor Bankole for that excellent session. and welcome you to the COVID-19 session. Yesterday, we heard from the inimitable Professor Larry Hadley about African solutions for problems that confront Africa. And this is particularly true in the midst of this COVID season. And I hope we'll have some of that during this session. The first presentation being COVID-19, mitigating the impact of COVID-19 on children's surgery in Africa. This is going to be presented by Dennis Mazingi. In a moment, the floor will be yours, but just to introduce my co-chair, Professor Bankole from the Ivory Coast, who will be introducing the alternate session. So Dr. Dennis Mazingi, the floor is yours.
Thank you very much. Let me just get ready. Okay, is everything looking good from your side?
We can see your slides clearly.
Okay, thank you. Okay, so good afternoon all, and thank you very much for the opportunity to speak to you today. After yesterday's session and today's presentations, they've really been excellent, and they're really a tough act to follow. So what I'm going to be speaking today is a topic that has really seized the attention of the global surgical community this year, and that's COVID-19. I put this slide up first to illustrate that we should all be concerned about the collateral effects of this crisis on those who are the most vulnerable in our societies, and those are women, adolescents, and children. And this is the outline of my talk today. So as we all know, an infectious disease caused by the SARS-CoV-2 virus first emerged in Asia and spread very fast across the world, becoming a pandemic early on this year. Naturally, the worst hit medical specialties were respiratory and critical care services. However, all parts of the global health system have been affected in different ways, and surgery is really no exception. Even though the effects are only indirect, you can imagine that when there's a crisis, it's the neglected stepchild of global health that will bear the brunt of the negative effects. And if you look at a timeline of events during the first part of the year, you will see how it played out. Very early on in the year, the surgical community quickly sprang into action. There was a lot of leadership among surgeons. And after initial statements and guidance from surgical societies around in the worst hit areas, associations from all around the world quickly followed suit and canceled surgical electives promptly. And this happened within about a 2 or 3 week period. And if I highlight the cases from Africa, you can see that while the cancellations happened all around the same time, the pandemic was in different stages in different countries. And you can see that the apocalyptic scenarios that were predicted for the pandemic here in Africa haven't really come to pass. Then in June, we got the news that perioperative COVID infection carried a very high perioperative mortality, further bolstering the arguments for the total shutdown strategy, although children were not really included in that study. And so this paper came out of that background. And in many ways, it was also a response to this paper from the Journal of Pediatric Surgery. It was a review of the pandemic and its implications for pediatric surgeons that described the situation around the world up to that time. And almost every continent was described in this review, but there was some notable omissions, as you can see. And so this omission, which is Africa, was startling because Africa is the youngest continent in the world. It's home to more than 700 million children and accounts for a large percentage of the global burden of surgical disease in children. And the unmet need is gargantuan. It is also surprising because as far as we know, Africa is the continent that will bear the brunt of the 28 million estimated surgeries that are going to be canceled during the COVID-19 pandemic. This slide is coming from a British Journal of Surgery article from the COVID Surge Collaborative. And so the aim of this paper was to explore the implications of the pandemic on surgery for children based on a handful of domains, and these are the domains here. There's some unique considerations in each domain, particularly in low and middle income countries that we should be aware of, and these can be considered either weak points or opportunities for strengthening the processes. There's some lessons from the past that may inform our responses in the future, either from a new pandemic or from second waves, and we provided some recommendations for strengthening each of these domains. So first up, surgical service provision. So as we said before, elective surgeries were canceled all around the world, and this has the potential to have some disastrous results. Elective cancellation is a common strategy meant to improve surgical capacity. Surge capacity, sorry. However, there isn't universal agreement about whether cancellation always achieves increased surge capacity. And there has been an argument that because of the huge burden of disease in Africa, maybe the benefits of that extra pandemic-related surge capacity may be outweighed by the potential harm of untreated high-risk surgical diseases. And I think many of the next presenters will talk a little bit about the magnitude of the impacts in their own environments, and the last presenter did so quite succinctly. However, there's some experience from previous pandemics that give us a clue as to what could be expected. So in 2003, during the SARS-CoV-1 epidemic, the rate of elective surgery in one hospital in Toronto fell by 22%, but resulted in only a small, modest increase in surge capacity that wasn't enough to raise the curve in that region. And this is something that's been replicated in other outbreaks, such as the MERS-CoV virus and also in the COVID outbreak. During this particular outbreak, the extra capacity that was created in Africa by canceling elective surgeries ended up not really being used because the huge influx of cases that was expected didn't really come to pass in Africa. Surgeons have also been deterred by the recent suggestion of an unacceptably high perioperative mortality, upwards of 24% in adults. However, there's some recent evidence to show that the mortality might not be as high in children. And then thirdly, the mobility of patients and their parents has been limited, therefore increasing the first and second delays in the patient journey. And this has led to a reduction in surgical volume and more complicated disease for certain conditions for the patients who do make it to the hospital. Healthcare workers. Now, this is a particular, something that I'm particularly passionate about. I think healthcare workers are the most important part of any pandemic response, more so than any one infrastructure item such as ventilators or oxygen supplies. And healthcare systems that already had baseline fragility in human resources for healthcare are likely to be the ones that will recover the slowest from the disruption. And these are just images from one particular African country that showed that there was pre-pandemic vulnerabilities, intra-pandemic vulnerabilities, and those vulnerabilities continue today. So threats to the children's surgery workforce include the personal health of healthcare workers, the effects of a chronically demotivated and undervalued workforce, and diversion of human resources for COVID activities. So in Sierra Leone, for example, during the Ebola outbreak, the surgical volume at one hospital fell by 97% when 1/4 of their surgeons unfortunately died from the disease. However, we're getting some recent data from this particular outbreak that suggests that infection and transmission rates in children may actually be quite a lot lower than in adults. So there may actually be a lower risk to adult staff members who are taking care of pediatric surgical patients than we previously thought. Secondly, in many African countries, healthcare workers' morale has been chronically low. And this has been playing itself out all across the world in high income and in low income countries in industrial actions or threatened industrial actions. And really fixing that problem goes beyond financial reward, but really protection for healthcare workers and their families, a feeling of being valued by their employers, and allaying the legitimate fears of healthcare workers. During the SARS, MERS, and Ebola outbreaks, healthcare workers were found to be reluctant to work because of fear either of contracting the disease and other multiple complex concerns. Some of the potential weaknesses in the pediatric surgical care continuum lie in guardians as well as visitors in pediatric care. So in low and middle income countries, as we all know, there's a significant involvement of guardians and other family members who give support to the mother and child. They assist the overburdened workforce, and they act as care advocates. They usually live on the hospital grounds, and there's frequent communication between and contact between the family members from inside and the family members from the outside. And the large guardian population in hospitals has been identified as a problem in the past, particularly unique to low and middle income countries and to pediatric wards. So in Malawi, for example, guardians accompanying pediatric patients were the largest group in the guardian population. And there was overcrowding as a result of there being more than one guardian per patient and also long hospital stay periods in some cases. Guardians are also present from the accommodation to the ward, as well as in theater. And so there's the potential for transmission between children and between families. So this is a bar graph showing that the population of guardians accompanying children was the highest in the whole population of guardians in Malawi in 2012. So as I said before, during times of crisis, it's really the most vulnerable that suffer disproportionately. And children is a key part of that. So pediatric surgeons often assume a very important role as a protector from non-accidental injury, and they're often able to offer refuge for children, either from an unsafe household or from negative interactions with family members. And this is particularly important when the traditional safe havens, such as schools, churches, and shelters are closed. So the hospital really, the hospital where surgeons take care of trauma patients is really one of the only safe places that is left. And with extended lockdowns, children will be spending longer at home, with the potential for increased proportion of household incidents, such as burns, falls, and other injuries. And I think there's data to support that from around Africa. And lastly, in training, there are some significant challenges that have been faced during the year, but also I think there's quite a lot of opportunities as well. Firstly, we have to remember that much of the workforce in LMICs is made up of trainees who have at this point been excluded from clinical areas to a large extent to reduce hospital populations, and because elective surgeries have been cancelled. Also, the surgical and anesthetic workforce is annually replenished by training and is constantly enriched by the training environment. And so there's going to be negative effects from not having the training environment part of the work of the work day. And then thirdly, we have goals for the surgical and anesthetic workforce that were set out by the Lancet Commission on Global Surgery, and that have been, and we have optimal levels for pediatric surgeon workforce density that have been calculated in recent times. And even though we've made significant progress towards reaching those goals, we're still far away from getting that, and that really depends a lot on training and consistently churning out surgeons. But there are opportunities for expanding the size of the classroom, for example. So whereas in the past, graduates would just have small silos where knowledge is shared amongst small groups of people, small clusters of trainees, now the classroom is essentially as big as we want it to be. And trainees can meet each other. There's expanded opportunities for cross-border collaborations, and that can only be a good thing. And one of the next presenters, I think, will actually be talking a lot more about those opportunities. So we presented, we've given some recommendations. This is just a selection of the recommendations we gave. However, for the full list of recommendations, I will refer you to the full publication. So in conclusion, really every medical specialty, pediatric surgery included, is going to have to deal with perhaps long-lasting disruptions to surgery. And we're going to have to figure out a way of kind of accelerating that recovery. Secondly, children's surgery in Africa in particular should be safeguarded from a potentially disastrous loss of surgical treatment. And then significant risks, but also opportunities exist for future second, third, or fourth waves or new pandemics. And this is a selection of some of my references.
Thank you very much. I think in the interest of time, we're going to move on to the next presentation, but thank you for that presentation. I'd ask presenters to stay within the allocated time limit. And if you have questions coming from the floor, please post them and we'll put those questions to the speakers. Thank you, Dr. Mazingi. Over to Professor Bankole.
Thank you, Dr. Niyi. It's my pleasure to meet everyone. The next speak is about audit of impact of COVID-19 on case numbers in pediatric surgery at Oxford University Hospital. So I will call Mr. Athanasios Tikaris. Mr. Athanasios is there?
I think Mr. Taraskis, he is not available. I've been looking for him now. Okay, I think he is. Okay, here we go. I'm going to unmute him. I couldn't find him. There we go.
Hi there, my name's Angus Fitchie. I'm one of the surgical trainees at Oxford University Hospital. Very nice to meet you all and thank you I'll be presenting on behalf of myself and Athanasios and Professor Lecoux. I wonder if it would be possible to share my screen. Is that all right?
You can go on.
Okay. So can you all see that?
Yeah, you can see.
Excellent. What I'd like to do is to talk to you about it's a very one-center experience, but it's just to give a flavor of what's been happening at a tertiary pediatric surgical center in the UK, and I'll talk you through what we've witnessed over the last few months during the COVID pandemic. So my name, as I said, is Angus Fitchie, and I'll be presenting on behalf of the Pediatric Surgical Department at Oxford Children's Hospital. So here is our place of work. I'll just lay out the presentation, cover a little bit of background of what's been happening surgically in the UK, talk about the aims of what we were attempting to discover, the methods, our results, a discussion, and then some recommendations at the end for how we might change what we've witnessed. So, as for background, in March this year, NHS England informed all NHS trusts that they must significantly reduce the planned number of elective surgical cases, that is the non-essential, the non-emergent operating. And the idea was that for the first, if that was done for 3 months, that it would free up 12 to 15,000 beds in England alone, which could be used to mitigate the surge in inpatient admissions during the COVID pandemic. It also, in those 3 months, it was estimated that 516,000 surgeries would need to be cancelled if this plan was to be enacted, and that was UK-wide. And what we're seeing now, so actually a few months on, this figure came out in June this year, was that the surgical waiting list UK-wide could reach in the order of 10 million patients by the end of the year, where this was, if there were to be perhaps a second wave of COVID, and if reduction of surgical capacity was to remain as hampered as it is at the moment. I would also note that an estimate worldwide is that 28 million elective surgeries will be cancelled or postponed as a result of COVID in this year, and that's a figure that's come out in the British Journal of Surgery in the last month. So these are both NHS papers that these figures have come from. Okay, so our aim in Oxford in the Pediatric Surgical Department was essentially to quantify our own reduction in pediatric surgical cases performed in this tertiary hospital setting in the UK during the COVID-19 pandemic. And the way that we aimed to do that was, firstly, by looking at case numbers from January to August this year, acquired from our theatre records and also from specific COVID theatre lists that were managed by our department. So then we took those numbers and we classified our cases as planned cases or expedited elective cases. Sorry, planned cases which could only be the expedited elective cases, so not the non-urgent cases, but those, for instance, in the pediatric setting, like incarcerated inguinal hernias in neonatal patients or preterm patients that were essentially going to be dangerous, would turn into emergencies if not addressed surgically. So those and the emergency cases, which of course needed to be done. We also gathered time points on patients' arrivals, operative start and finish times, recovery times, and returning to the ward. And we looked at what time the first case of the day was performed. So in order to compare, as a baseline, we used January and February, the months that were not affected by all that was happening with the COVID pandemic. And then we compared that to what was going on later in the year. So looking at our results, we can see that in the caseload, there was a drastic reduction. So if we take an average for January and February together as our baseline of 143 cases total, but that's 87 planned and 56 emergency. Even just in March, we're seeing nearly a reduction in half of the number of the planned cases and significantly in the emergency, on the emergency side as well. So if we look down below at the second table, we've basically plotted the percentage of the baseline operative capacity, and you can see that April is the most significant month, the most significant effect on surgical capacity, where the total was only a third of total number of cases performed was only a third of what we were able to achieve in the pre-COVID baseline period. Over the months of the summer, there was something of a recovery, and I'll discuss why that may have been in the next few slides, but a significant reduction that we noticed. And here's the same information portrayed as a graph, and we can see April, as I've explained, was the most significant reduction. And here's another graph which is indicating the minutes of operating time, which really demonstrates the same results. So we can see that there's a transition period in March, and then April, May and June are vastly reduced. And I might explain, or I might justify that we saw that the number of cases had seemed to have reduced most in April, but the minute reduced most in May and June. And one explanation is possibly that our approach to managing some of our surgical cases has changed. Not only, essentially not only how we're operating, but choosing whether to operate or to manage conservatively. And I'll come on to that a bit more in a minute. But the big change in our cases here is I'm talking about management of appendicitis, and there's a trial ongoing in the UK at the moment for conservative management of appendicitis during this COVID period, in order to minimize operating time and keep operating theatre staff safe, as well as patients, to minimize the time that all staff and patients are involved in the operating environment. Okay, here again is a table that shows the timings at which the first pediatric general surgical case was arriving to the operating theatres on each working day. So we can see that whereas it was around 9 o'clock at our baseline, it is pushed back to latest 10 to 10 in April. And there are various reasons for the delays here, which I will explain as we continue. In a discussion, we've seen a decline in capacity that greatly affected our planned and emergency operating, with only a partial recovery, and that recovery was seen more on the emergency side than the elective side, and that has to do with different surgical services competing for a limited number of operating lists. Not only were pediatric surgical consultants and teams using the allocated theatre space, but different specialist pediatric surgical services were also, and a lot of inter-team communication and vying for very limited theatre availability was taking place. I mentioned that a proportion of appendectomies are being, or a portion of appendicitis, excuse me, are being managed conservatively. As I said, this is a UK trial going on at the moment, and it's impacted on the number of cases being taken to theatre at the moment. We're seeing the current figures are showing approximately 10% return to a complication rate from the conservative management. So patients who are treated with antibiotics are discharged on a follow-up plan of callbacks, but then end up returning and needing an appendectomy. And at the peak of the pandemic, the elective, so the essential non-urgent operating fell by 75%. There's a persistent delay in operating start time, as we saw it was worse in April, and that's due to new protocols around getting patients to theatre. One of them being that every patient needs a COVID negative swab in order to be suitable for a theatre pathway. If they do not have a COVID negative swab prior to their operation, there are significant delays and reordering of lists, and therefore there's a meeting every morning looking at the operative lists and checking to see that these COVID swabs have been done either in the community or in hospital 24 to 72 hours prior to the operation. And you may imagine that causes sometimes an administrative nightmare in the preoperative planning. A quick couple of recommendations just coming to the end. That there needs to be ongoing transparency and communication and work between managers, anaesthetic teams, theatre staff, and surgeons from different teams to find greater capacity with new protocols that have been elaborated during this period. This is an ongoing process, and there have been many changes and many new protocols, and I think underlining it all, it's so important to be flexible and understanding of the different priorities and different and the different concerns of all of the members of the team. And then one thing that has been put out by the Royal College of Surgeons in England, that is a very sensible framework for trying to recover our surgical services, is this template of points that really is in essence pinpointing some of the key solutions for recovery of not only elective but emergency surgical capacity. So firstly, keeping a close eye on timing of delivery of surgical care, testing for COVID in patients and staff, providing adequate personal protective equipment, and ensuring that interdependent services have capacity. So that's radiology, anesthesia, critical care, and then coordinating all of this on a local level. from a leadership point of view, establishing local governance teams that are multidisciplinary with regular meetings, and harnessing the use of virtual meetings to ensure that communication and planning is timely. Then to enhance the surgical workforce by essentially trying to retain staff who may be returning to work or retired, or hiring additional staff, reassigning staff based on their competencies, and redesigning job plans that are in existence, or revised job plans. Supporting surgeons is incredibly important. So that would involve testing the surgical workforce, providing adequate PPE and universal precautions, and considering things like stress and fatigue in order to continue to provide the surgical service, and also to preserve the key elements of training, which are so often lost in a situation that can be quite chaotic. And lastly, the focus of what we are doing must be the patients, and to communicate to the patient and patients' families that can take place virtually, but also around the hospital environment, to provide guidelines and updates on changes to the surgical service, and to increase understanding in the community of the challenges that we're working through. Also a key point being to plan for post-operative care, because many of the post-operative services in the community have been greatly affected in terms of members of staff that are shielding or unable. The capacity is greatly reduced. So I think that that really encompasses what we have looked at, and also some ideas for how we might move through that can be applied more universally as well. And I would say thank you very much, and perhaps questions we should save for later on. And I'll stop sharing now. Thank you very much.
Thank you, Dr. Afchi. So we will move to the next speaker because we have no time for question. So I give the floor to Dr. Nii. Dr. Nii.
Thank you very much. The next speaker, speaking about online planning forums to develop a roadmap to mitigate the impact of COVID-19 on the delivery of global children's surgical care. So the floor now to Alize Abbas. Please keep your presentation succinct. There have been lots of questions asked, so give us an opportunity to ask questions.
Thank you very much. Thank you very much. Hello, everyone. Thank you so much for the opportunity to talk about this on behalf of my team and the Global Initiative for Children's Surgery. So I don't have any disclosures, no conflicts of interest. So as we know that the COVID-19 pandemic has affected 35 million people to date and has led to more than 1 million deaths. Data has shown us that a lot of very few of these cases occur in children who also experience milder forms of the disease. But are these numbers truly reassuring for healthcare providers that care for children? According to a study that was published in May in The Lancet by Robertson and colleagues, they showed that because of disruption in essential child health services, that includes routine immunization, provision of antibiotics, there can be an estimated 200,000 to more than 1 million deaths within the next 6 months in 118 LMICs. But once we have this knowledge, we ask ourselves, what about children's surgery? So keeping all of this in mind and the potentially devastating impact that the pandemic can have on the delivery of children's surgical care, the Global Initiative for Children's Surgery began publishing resources on its website and then decided to organize 2 action planning forums. So for the action planning forums, panelists were chosen from different parts of the world with a particular focus on low and middle income countries, and there was representation from multiple children's subspecialties. The first action planning forum focused on the challenges that providers were facing in different parts of the world and how they thought children's surgery would be impacted now and in the future. Based on whatever was learned from the first session, The second action planning forum focused on understanding what the needs of the providers are and where GICS, as well as other stakeholders, could help, specifically for educational resources, for guidelines, backlog of patients, and for research. The reason that these sessions were called action planning forums and not webinars was because there was an emphasis on them not being didactic or lecture format, instead sort of trying to have a reciprocal understanding from both the providers as well as the moderators, as well as some input from the attendees in the form of chat questions. So there were notes and transcripts that were taken from this action planning forum, and we used a qualitative data analysis approach using MaxQDA. And in an inductive coding process, we identified codes, categories, themes, and sub-themes until thematic saturation was reached. In order to minimize any potential bias, both the moderators as well as the panelists were not involved in coding. Once we identified these themes and sub-themes, they were categorized according to the optimal resources for children's surgical care document and the framework domains that you see on the slide. So our results showed that we had a very strong participation in the first APF from 44 countries and in the second APF from 33 countries. In addition, there were 364 attendees in the first and 157 attendees in the second APF, with additional viewings of the recordings on YouTube. Just an important thing to remember here is that these total numbers surpass all the prior in-person GICS conferences and the number of attendees that we've had there. So once we did the thematic analysis, 6 major themes appeared when panelists talked about the challenges that they were facing. And the most frequently reported challenge was cancellation of elective surgery, followed by delayed access to care, fear among the patients as well as the general public. Unavailability of personal protective equipment was also another challenge. And then diversion of resources away from children's surgical care toward COVID care as well as ICU care, such that one of our panelists said that because many of the central hospitals in the larger cities were converted to COVID referral hospitals, the number of pediatric beds decreased drastically. And this is true for a lot of reports from different parts of the world, giving us an insight into the challenges that children's surgical care providers are facing all over the world. And lastly, there was an interruption in hands-on training that was seen. So the impact of these challenges in the pandemic can be summarized firstly as panelists expressing their concern about there being delayed or absent access to surgical care because of the lockdown, because of financial burden, and because of fear of coming to the hospital, which can lead to more advanced disease presentation, which can ultimately lead to increased risk for complications, morbidity, mortality. And as we know that there's catastrophic burden, financial burden on families, as well as on governments and healthcare institutions, in addition to the disrupted training that was seen. In the second action planning forum, because there was an emphasis on trying to identify realistic solutions that could be rapidly funded as well as implemented, there were 3 key ORIX framework domains that were highlighted, namely quality improvement, human resources and training, and then service delivery. So there was an emphasis on strengthening surgical workforce capacity by involving local providers as well as using telemedicine. And then our panelists almost unanimously agreed on there being multinational funded studies that should be started, focusing on looking on surgical outcomes for COVID positive children, looking at the financial burden incurred by families, hospitals, as well as governments, safety of procedures, and the long-term impacts of deferred surgery or delayed surgery. There was also an important emphasis laid on adapting all solutions according to local needs and languages, recognizing the linguistic diversity and the limited English proficiency that exists in different parts of the world. And lastly, there were 4 key themes that emerged when panelists were asked about guidelines, where they said that safety, both of the procedures and the people involved, adaptability of guidelines, prioritization of procedures into emergency, essential, and then elective, and lastly, accessibility of these guidelines should be the top priority moving forward. So what do these action planning forums currently mean? So firstly, this is the first of its kind series of APFs that have been conducted dedicated to children's surgery during the COVID-19 pandemic to get a targeted needs assessment of the global children's surgical community in a participative manner instead of a lecture or didactic manner. And lastly, and very importantly, we know that the optimal resources document focuses on optimal resources for optimal care. But as we can see over here, there were almost all the framework domains that were present in ORIX did fit into the analysis that we got out of ePAPSA, telling us that ORIX is in fact applicable even in situations where you don't have optimal resources, where resources may be threatened or limited. And lastly, a very important implication and effect of this is now we have a clear roadmap. In May, we understood where we stand, but there was limited knowledge about children's surgery. By July, we had an understanding of what our actions are. And with this list of actions, GICs, donors, philanthropists, healthcare policy makers, governments, they can all come together to work on these interventions, which are currently underway. And then in the next couple of months, as well as the coming years, we can look at how effective these interventions are. Of course, the strengths of our study, we truly believe it is a novel and important study because in addition to doing a comprehensive needs assessment, what we've also done is provide an objective and a transparent method of analyzing and presenting findings and reports from online sessions, from action planning forums, webinars, which can be replicated in all parts of the world by future researchers. But we must also remember there are certain limitations to the study. For example, there were some participant questions that we could not answer in the given time. Other than that, because interventions and planning is still underway, the real world effects and what the effectiveness of these APFs is still a question mark, which will possibly be known in the coming months or years. And lastly, even though some of the proposed solutions were definitely potentially very impactful, because of it was just beyond GICS's funding capabilities, which is why they may not be able to be implemented. So to conclude, I'll say that we understand there have been great presentations before myself that have talked about how the COVID-19 pandemic is affecting children's surgery as well as surgical systems worldwide. But we must keep advocating for the fact that children's surgery will be disproportionately affected. So we need to identify challenges, but not end our work over there. Also propose solutions which are applicable to all parts of the world and not just high resource settings. And using this data-driven approach, that's what we have aimed to do via this study. And lastly, we know that the ORIX document has been a source, a valuable tool in trying to strengthen children's surgical capacity, in trying to develop children's surgical capacity where none exists. But this study is one of the first pieces of evidence to show that ORIX is also helpful in trying to protect children's surgical capacity in times of crises, such as the COVID-19 pandemic. These are my references. And thank you so much to the Global Initiative for Children's Surgery for the opportunity to present, especially to Dr. Lubna Samad, Dr. Marilyn Butler, and Dr. Duro Coscaris for their continued support and guidance on this project. And thank you to all the panelists and moderators of the APFs. Thank you everyone for listening, and thank you, ePAPSA, for the opportunity to present.
All right, thank you very much for that succinct presentation. It'll allow us one question, and I'd be grateful for a succinct answer. If there were a second significant spike in Africa, can you highlight one specific lesson learned from that process that you would wish to emphasize?
So that's a great question. Thank you so much. I think the first and foremost thing would be having prior knowledge. That would be one of the biggest things that would help providers, governments to tackle that second spike, because that was some of the things we saw from our panelists who had dealt with a similar epidemic before, for example, so they knew what were the things that they had to work with. So I think that would be the most important, not having the knowledge for this process.
Okay, thank you very much. In the interest of time, we'll move on. And the floor is back to Professor Bankole, if your connection is okay.
Yeah, thank you. Thank you, Dr. Lee. I will call now Nimaya Stella Alice about implementation of online teaching format led by pediatric surgery fellows in Uganda due to COVID-19 educational disruption, an interim report. Dr. Nimaya, you have the floor.
Thank you very much, Professor Bankola. Good afternoon and good evening. A report. It was an implementation of an online teaching format, and this was led by the fellows, pediatric surgery fellows in Uganda, due to the disruptions that COVID-19 had on education. So this is each and every one that was a part of this and still is a part of this. So basically Uganda, just like any other low-income country, has a scarce number of pediatric surgeons available to meet the needs of the population. So in addition to the demands that the population has, there's also the demands that the trainees have on their education. Now, the College of Surgeons of East Central and Southern Africa, COSEXA, has provided an opportunity to have surgeons generally trained within their own countries. And there's no debate about it that training a surgeon at home is much cheaper and much more convenient as opposed to training a surgeon elsewhere abroad. In addition to the fact that for the fellowship slots internationally, they usually few, and with no offense, most countries are more biased to their own trainees as opposed to those outside. So being able to train from home is actually more of a luxury. Now, Global Surgery, on the other hand, has provided a platform for international collaborations. And in this way, you'd worry about home-based training being limited in the fact that the kids are and don't have much, but surgery and what there should be this collaboration. Surgery in Uganda.
Okay, we seem to be having a problem with the online connection for our current speaker. We'll give that a moment, see if we can resolve it. And if not, we may need to move on.
Nia, if the speaker has lost the connection, I think it was quite a low bandwidth, we can potentially move to the very short poster session, which is scheduled as next, if she's not back online already. And then we can see if we can accommodate her talk again afterwards. Is Dr. Nemanja Stella Ellis back with us? I can't see her.
If the posters are ready, should we do that in the interest of time?
Let's do that. Mahmoud, if I can just ask you to share your screen. What we will do is we'll give 10 minutes. The posters will be just rolling one after the other one. Colleagues can watch it on their screens. So it is, my time is 17:15 at the moment, is the Central African time. So we'll give it for 10 minutes. It will run, and if you want to just grab a quick cup of coffee or have a look at the posters, you'll be able to do that. And at 17:25 we will be back, and we will have our invited guest speaking at 17:25 in 10 minutes from now. Thank you. Mahmoud, I can see the slides, but we just need to put it on slideshow. Perfect, thank you. Thank you very much, Mahmoud. If you can take the posters down now, we are at 1725. Mahmoud, are you able to hear me? If you can just take the posters down. Okay, Kokila, I've just unmuted you. You should have your microphone on any second.
Okay.
Thank you. Kokila,
Can you hear me?
Floor is yours, and yes, we can hear you. Thank you.
Okay. Well, again, it gives me great pleasure to introduce Professor Maguti from Zimbabwe. My first meeting with Professor Maguti was when he opened the children's theatres in Kigali. So he's a great advocate for children's surgery. Professor Maguti is the president of COSEXA, and he's also the professor of surgery and chair of the Department of Surgery in the College of Health Sciences in Zimbabwe. He's also a clinical professor in Stanford University, USA, and he's the medical director of the Avenues Clinic in Harare. Besides clinical work, he has done a lot of work in commissioning in Zimbabwe, and he's the commissioner on the Zimbabwe Health Review Commission. He's also the founding president of the Surgical Society of Zimbabwe. And besides clinical and commissioning work and advocacy work, he's also been the past editor in chief of the Central African Journal of Medicine and played a very important role in developing research in Zimbabwe. In 1997, he was awarded the honorary fellowship by the Royal College of Surgeons of England. And in his clinical work, his main interest is general surgery. But like most surgeons in Africa, he has done general surgery but taken a special interest in plastic and reconstructive surgery. So it gives me great pleasure to welcome Professor Godfrey Maguti to our platform.
Thank you, Professor Laku, and greetings to everybody. Can I share my screen?
Yes, you may. Go on.
Is it clear?
Yes.
Can you see the slides?
Yes, they're clear, Godfrey. They're clear.
Okay. So this slide shows the what we call the COSEXA region, which is the region covered by the College of Surgeons of East Central and Southern Africa. It has got 14 constituent member countries, but it conducts training in surgery in 18 countries. And this roughly covers about 500-600 million people, which is about half the population of Africa. This is the mighty Victoria Falls. It's a UNESCO World Heritage Site, and one of the 7 wonders of the world. Is the major tourist attraction to Zimbabwe. This is the layout of my talk. I'll give a bit of the background to COVID-19, look at the impact on surgical services, impact on surgical training, education, and examinations. This slide shows the story of COVID-19, how it has spread, throughout the world, starting in China and coming to Africa about 6 weeks later, starting in Egypt, on the 14th of February 2020. In Southern Africa, we witnessed it on the 27th of February in South Africa. And in my own country, in Zimbabwe, we had the first case on the 20th of March 2020. This shows the global burden of COVID-19. And we can see that the pandemic has taken a very severe form in Asia, Europe, North America, and Latin America, and has been quite mild in Africa and in the Middle East. Why mild form of COVID-19 pandemic in Africa? There are a number of reasons we think, why this has been mild in Africa. First of all, the governments in Africa had watched the pandemic unfold in Asia, Europe, and the Americas. And so when it first hit Africa, the governments were quick to implement the measures recommended to prevent the spread of COVID-19 by the World Health Organization. And fortunately, there was ready acceptance of safety measures by the populations in Africa. An analysis that was done in a study showed that there was a take and acceptance by the population of up to 85% of all the safety measures that were recommended by the World Health Organization. The population in Africa is relatively young. The average age in Italy is about 47 years, and in South Africa, 27 years. And according to WHO data, the median age in Africa is actually 19 years. And there are very few or fewer old age homes in most parts of Africa. The climate is also favorable. There was an interesting study that was done at the University of Maryland in the United States, which found a correlation between temperature, humidity, and latitude with the spread of COVID-19. And there was already, as has been mentioned earlier, good community health systems in Africa. We know the DRC, Democratic Republic of Congo, and parts of West Africa have battled with Ebola at times in the last decade or two. And so they had systems in place of dealing with these very difficult pandemics. And in most parts of Africa, there are immunization teams which are already working in the communities. And governments took advantage of these teams for public education to conscientize the population about the dangers of this pandemic. This is an interesting slide, which I'd like you just to watch to see how COVID-19 has quickly become an important cause of death within a space of 6 months. And over this period of time, if you watch the slide closely, you will find that it moves right up to the top, overtaking malaria and malnutrition to come right at the top as a cause of death. A very important slide, this one, showing that the burden of the disease is between the ages of 20 and 60, and that males are a bit more affected than females. But look at the orange and yellow graph, shows that the burden of the disease is right at the top end of the age spectrum, between the ages of 60 and 80, and virtually not much down below the age of 50. This is a world map taken of mortality from COVID in 1 week in September, and just shows that the impact in Africa is not very high compared to, say, South America, the United States, and some parts of Europe. So the response of governments in sub-Saharan Africa were quite aggressive because they had seen the impact of this pandemic in Europe, Asia, and the Americas. So when the infection first struck Africa, the governments were quick to close the borders, institute lockdowns, and institute the use of compulsory face masks, and emphasize on social distancing. And also, as much as possible, testing for COVID-19, and put in place arrangements for active contact tracing. Within the country, they encouraged self-isolation, and this was enforced by public health workers. And for those coming from overseas, quarantine facilities were introduced. And most of the countries were also quick to set up designated COVID facilities. And in quite a number of countries, allowances for health workers on the front line were instituted. Looking at the impact on surgical services. So having seen how the pandemic unfolded and its ravages in Asia, Europe, and the Americas, African ministries of health were quick to advise the closure of outpatient departments to reduce the risk of infection and spread of COVID-19, and also to conserve critical human and material resources which would be required to fight the pandemic. As a result, there was cancellation of large numbers of elective operations, and this has created a large backlog. Consultations, where possible, have been carried out on telephone and online, and the closure of outpatient departments has very severely impacted the teaching of both our undergraduate and postgraduate students. With hindsight, we should have reduced the activity in outpatient departments, but probably not completely close the outpatient department, because so far the impact of COVID-19 in Africa has not been anywhere near what we've seen in Europe, the United States, and Asia. Accident emergency departments have remained open throughout the pandemic, but the main challenge has been to keep the right complement of staff within the accident emergency services, because some of the staff become infected and they need to go in self-isolation or be admitted into hospital. And it has not always been possible to replace, the manpower that, takes time off duty because of infection. There have been challenges with personal protective equipment, but hospitals have tried their best to try and ensure that staff have access to appropriate personal protective equipment. There have been sessions, carried out in most institutions to train staff on the proper way of using personal protective equipment and also handling emergencies. Facilities for screening have been set out outside accident emergency departments, where travel history is taken, any history of contacts, temperature check, sanitization, before patients actually get into accident emergency department. Suspected cases at this stage are sent for testing. If the patients are ill, persons under investigation wards have been set up where patients can be treated while waiting for their results. Operations on emergencies and suspected COVID-positive patients, the health services have continued to give high priority to all patients requiring emergency operations through the course of this pandemic. The taking of informed consent has been modified to make sure that it addresses the issues related to COVID. So has been the checklists used in theater. In addition to the WHO checklist, we now have also to complete the COVID-19 checklist looking at issues specific to COVID. Patients who undergo emergency operations whose COVID status is not known should be treated as if they were COVID positive to minimize the danger of infection to theater staff. And there should be theaters that are dedicated to emergencies, and appropriate cleaning and disinfection facilities should be available after every case. And it is also important to ensure that all specimens are double bagged and handled wearing gloves. Special precautions have to be taken with aerosol generating procedures. And during the course of this pandemic, we've seen activity in the endoscopy departments almost coming down to zero, but where we have to carry these endoscopy procedures, adequate PPE should be donned, and also wherever possible, the COVID status of the patient should be established before the procedure. And special precautions are taken if the patient requires intubation, and only the anesthetist and the assistant should be in the anesthetic room. Where possible, regional anesthesia should be preferred to general anesthesia to minimize the dangers of aerosol generation. I've already addressed the issue of training staff in the proper donning and doffing procedures so that they know exactly how to use the PPE, and to cut on theater time and maximize efficient use of resources. The most senior member of the team should be carrying the operation, and this unfortunately has impacted negatively on the training of our postgraduate students. Also, only essential equipment and staff should be in the operating theater, and the runner outside the theater should be available to supply additional resources. If the patient has to be extubated after the operation, only the essential staff should remain in theater. We've also continued to look after urgent cases, in particular emergencies. But initially, when we come into contact with these patients, it is preferable to conduct the consultations by telephone or online, and if possible, to organize investigations before the patient actually comes for a definitive consultation. And when they come with all these investigations, appropriate arrangements for treatment can actually be made. Where appropriate, neoadjuvant therapy should be administered and definitive surgery delayed to a later date. It has become very important for urgent cases, and in case one is dealing with elective cases, to establish the COVID status of the patient before they are subjected to surgery. As I mentioned at the beginning, elective cases have eventually been postponed during this COVID era, and this has created large backlogs. But now, with a better understanding of the magnitude of the pandemic in sub-Saharan Africa, serious consideration is being given in our health systems to open the outpatients department so that we can perform some elective operations. This to the benefit of the patients, and especially for us working in training institutions, to the training of both undergraduate and postgraduate students. And within Africa, like elsewhere, most countries have now specifically designated COVID facilities and separated them from facilities where patients who are non-COVID are being treated. And with this arrangement, it should now be quite possible for the full range of clinical services to take place in the non-COVID facilities of the health sector. This is a slide from a study, which was a multi-center study in 560 hospitals in 60 countries over a 12-week period, which shows that 28.4 million operations were canceled, 2.3 million of which are cancer cases, and a total of 72.3% cancellations of surgery. My own country, Zimbabwe, was part of this multi-center study, and there were 9,717 patients who were cancelled over this period, 968 of whom were cancer patients. And it is estimated that it will take 11 months to clear this backlog of operations. What is the way forward? So the COVID pandemic has forced every country to have homegrown solutions to its challenges, especially those pertaining to personal protective equipment. Because as we've watched this pandemic unfold, we've seen well-resourced countries like the United States, the UK, Italy, and so forth, struggling to actually meet the demands for personal protective equipment. So you will find that in most countries, technical colleges and universities are now producing masks, face shields, goggles, also producing surgical gowns and producing sanitizers. Quite a number of countries within Africa have started manufacturing ventilators, which they have not done in the past. And this in my own country is also going on. I'm aware that in Kenya and Ghana, they've also started producing ventilators. I'm sure other countries are doing the same. The repurposing of PPE has reinforced in the psyche of health workers the need to preserve special resources that in our environment are always limited. And we hope that this becomes a new normal to the health personnel in the health sector. Also, the future design and construction of our health institutions should take into account the possibility of new and complex diseases like COVID-19. It has become very clear that we need to strengthen our procurement procedures because, as we've witnessed in a number of places, including my own country, there have been quite some significant leakages of resources by senior administrative personnel in the health sector. Now, looking at the impact on education, in the COSEXA region, the council of the college is the engine that drives the programs of the college. And due to travel restrictions, lockdown, border closures, it has not been possible to have physical meetings of council to discuss the important business of the college. And virtually all meetings that we have conducted to date have been on the Zoom platform. And this has actually become the new normal. We have observed in council that business can be conducted very successfully through virtual meetings. And this has resulted in a significant cost saving for the college, because as most of you are aware, travel in Africa is very expensive. The post-COVID-19 council will have to have some physical meetings because this is inevitable, but we've seen that we could continue to conduct most of our meetings on the virtual platform to cut on costs. Profound disruption of all education and training activities has occurred because of the COVID pandemic. And I've already alluded on the very negative impact of the closure of outpatients department on clinical teaching of both undergraduate and postgraduate students. Same with the cancellation of elective operations, especially on technical operative skills of surgical trainees. Due to the need to conserve limited resources and to cut down on time during emergency operations, it has meant that trainees have been deprived of carrying out a substantial number of emergency surgical procedures. And we have witnessed that they've been struggling to meet their logbook requirements because of this all these constraints. Surgical simulation has been going on even before COVID, but it has become even more important during this era. One of the positive effects of the COVID-19 pandemic is the explosion of the virtual learning platform, which means students and surgeons can now participate in conferences, online conferences, webinars, in the comfort of their homes and participate in these sessions happening all over the world. This year, COSEX has successfully administered all its written examinations online, and this is a big milestone for the college and will become the new normal for us. We are looking in this December and January to administer a blended clinical examination with some of the examiners online and some of the examiners on site. And we've witnessed all over the world virtual graduation ceremonies as a result of the COVID pandemic. I thank you.
Thank you very much, Godfrey, for a very insightful talk and taking us through the journey of COVID from a global perspective through the COSEXA countries to your own home country. I think you're looking forward and your solutions to some of the problems and the positivity, some of the positivity that's come out of the COVID era, it's very helpful. So thank you very much for your talk.
Thank you.
Thank you very much, Prof. Moguti and Kokila for chairing the session. We're going to be moving to the next session, which is got the free oral presentations. And I would ask Professor Dan Paniori and Dr. Bruce Mualani to take us through the session. Thank you very much.
Thank you very much. What a pleasure to be here with you. I'm Dan Panaro, a pediatric surgeon, involved with our precious organization, ePAPSA, for so many years. And it is extremely exciting and optimistic for me to think about our early meetings a couple of decades ago and through multiple on-site meetings, and here being hit by the current pandemic and yet coming up as an organization with a beautiful online meeting and an extremely high quality of the presentations. I really want to state that we've had some of the best presentations we've ever seen at ePAPSA already. Much of the meeting has focused, of course, on the pandemic, but it's interesting that most of the COVID talks were not about how to treat children with COVID, but rather on the collateral damage that has happened over this period of time. And the reality is that children with congenital anomalies that we're called to treat, to whom we have a mission to treat, have been suffering. And this last free paper session actually deals with that and brings us back to the conditions that we have learned to treat and we love to treat, and we want to continue to improve our care of. I will be joined in chairing this session by Dr. Vulani, and that's particularly special because he comes from Zambia, and that was where we were supposed to meet. Unfortunately, we couldn't do it, but at least he's with us for this meeting. So we'll get started. I would just like to remind the presenters again to stick to the ideally 8 minutes for the presentation to allow them to have a question. Otherwise, we will have to stop and continue after 10 minutes. We'll start directly with our first presentation, And this takes us right to where this association has done so well in recent years, and that is looking at congenital anomalies in low and middle income countries and trying to get research answers through multi-center collaboration. So the title is Management of Outcomes of Gastrointestinal Congenital Anomalies in Low, Middle, and High Income Countries, a multi-center international prospective cohort study, which will be presented by Dr. Mahmoud El-Fiki.
Thank you for the opportunity to present here. And thank you everyone in the ePAPSA and everyone from the Global Page Search Collaborative to present this work. It's really an honor to be here. And I hope we'd meet sometime soon all. You see my screen?
Yeah.
So this is the management and outcomes of GIT congenital anomalies in low, middle, and income countries, high income countries. It's a multi-center international prospective cohort study. On behalf of the Global Page Search, I'm honored to present this work. And I can see many of my colleagues already, Dr. Naomi Wright, Dr. Adesoji Ademoya, already online in this session. So I hope their content was what I'm presenting. To give a background about the study, congenital anomalies present about a third of all infant deaths globally. There are more than 500,000 annual deaths of all babies born. More than 97% of deaths are in low and middle income countries. And you can see that according to the World Bank, low income countries in both sexes, congenital birth defects are the third or fourth major factor for death. And there's an increasing burden on the low and middle income countries because the infrastructure just can't handle all these deaths, and it doesn't have all the infrastructure to support them, which is contributing to more deaths. There's also very little data from the low and middle income countries. It's mostly due to lack of registries, and that not of all cases get diagnosed because of people living in villages or in rural areas. There's always a challenge of reaching to primary or secondary healthcare facilities. So it's really a burden and a challenge to early diagnose and to treat these cases. There's also very little data, published data, mostly from single institution studies about these cases and how these cases can be diagnosed and presented and treated. So the aim of the study was to undertake a multi-center international prospective cohort study of all GIT anomalies across the globe, comparing outcomes in low, middle, and high income countries as the primary outcome. The methodology we used we started recruiting a year, almost in October, November 18, and almost more than 1,374 collaborators joined the study. Over 260 hospitals joined from over 74 countries across 12 languages. And it's really a big effort for the team to gather all these cases and all these team to join. We focused on mainly 7 congenital anomalies, mainly the common pediatric surgery anomalies, mainly esophageal atresia with residual fistula, congenital diaphragmatic hernia, intestinal atresia, gastroschisis, exomphalus, any rectal malformations, and Hirschsprung's disease, over a minimum of 1 month period of any of collaborators whichever they chose. Sorry. We started in October 2018 and we ended the study in April 2019. And the primary outcome was an all-cause in-hospital mortality. And we've done a statistical model of multi-level, multivariate analysis for the whole case of the study. There were almost 3,800 cases gathered, and primary outcome mortality was the highest in the gastroschisis with over 450 cases collected. And you can see that it was really significant in middle and low income countries where over 90% mortality, which goes down in the middle income countries to almost 32%, and in the high income countries to nearly 1.5%, which was a huge significant value. The second outcome mortality was in esophageal atresia, where almost 86% of the cases passed away, and a less number of cases, over about 29% of the cases in middle income countries, and to a lower 7% in high income countries, which was again quite significant. Our third outcome was in the CDH group of about 450 cases again, which we didn't have much data in the low-income countries, but about 40% of the cases passed away in the middle-income countries and 14% in high-income countries. And you can see that the rest of the cases were almost the same in the intestinal atresia and rectal malformations and Hirschsprungs, which were really non-significant difference. So the most factor associated with high mortality was the country income category. We can see a hazard ratio of 2.78 in the low income countries versus middle and low high income countries, where it goes down to 2.11. Ventilation was needed but available was a 1.96 hazard ratio, and ASA score was also significant. Receiving a blood transfusion, which was also significant, was you can see receiving ventilation. Further unplanned intervention was again another factor which proceeded to high mortality. Having a no surgical safety checklist, which reaches back to the previous presentation from my colleague, that the WHO checklist should be always presented and should always be used. Parental nutrition needed but unavailable was also a factor for a higher mortality ratio. Sepsis at presentation was a higher mortality, and additional anomaly, which was undetected, probably using antenatal care or even at birth, was another higher mortality factor in these patients in all. Factor associated with low mortality was an induced vaginal delivery, which contributed to a lower mortality ratio in all cases. Receiving parental nutrition helped in reducing the mortality. Using a PICC line or using a percutaneous central line also was a major contributing factor in reducing mortality. Having cesarean section was a factor, and higher presenting weight or presentation gestational age again contributed to a lower mortality, which is again given that it has a better outcome. So in conclusion, there were significant disparities in mortalities for different common GIT anomalies globally along the different high-income countries or middle-income countries or lower-income countries. So a rapid action is required through a coalition of global stakeholders to address the inequity of timely access to quality neonatal surgical care. That includes education, research, or training of surgeons, or even the whole team, nurses, antenatal care providers, or neonatologists. And the focus should be used on antenatal diagnosis and delivery at a pediatric surgical center. Also improving district level diagnosis, resuscitation, and timely safe transfer between primary and secondary and tertiary healthcare facilities. The last thing is preoperative care to tertiary level at surgical safety checklist, IV access, parental nutrition, and ventilation to neonatologists, premature babies, and all cases with congenital anomalies should be very highly questioned and very highly trained. I would also like to mention that the research training and fellowship and academic mentorship scheme presented by the Global Pet Search, it's already starting with online webinars and which will be available to download from the website, and the 2-year academic mentorship scheme. And you can see many many contributing here from Africa in this study and these webinars and these mentorship schemes. We already have many people signing up, over 260 signed up, and the mentorship scheme has over 200 signed up. And there will be a prizes presentation in November 2020. Thank you for all the team members in the Global Pet Search research collaboration from all around the world, and to the Wellcome Trust and all involved stakeholders at the King's Center for Global Health and Health Partnerships at the King's College London. And you can have all the information available on the website, and you can see the published protocol at the BMG Open. Thank you again. And
thanks very much, Dr. El-Fiqi, for beautifully staying right within the 8-minute time period, which means we do have time for a question or two. Please raise your hand up if you have a question, and the host will be able to put you on, to unmute you, or write your question on the chat box, and I'll be able to read it for them. Let me just start with one question. I noticed in your data, Dr. El-Fiqi, that there was no mortality stated for CDH, for congenital diaphragmatic hernia in low-income countries. Is that the hidden mortality that we know of? Did you not really have any cases of CDH in your study from those countries?
I believe we've recorded a few cases, but I'm not sure why we didn't analyze the data. I think maybe there was missing information that we didn't have all the data ready. Perhaps Dr. Naomi Wright would have more information about them. And again, all these results will be published hopefully soon for everyone to see.
Thank you. There is a question in the chat room that there's at least is antenatal diagnosis in the least developed countries a realistic solution or option?
Well, it's a thing we should opt for. I mean, if we know what the problem is, we should try to fix it. So this is how we should start, and then we move on to how to.
Thank you. Thank you. And I agree that, in fact, this meeting is here because we're committed to have these things available and to have equitable care for children across the world, regardless of where they come from.
I see, Dr. White, answering your first question, that it's like that the cases, the CDH cases occurred, but were not diagnosed or didn't make it to the pediatric surgical center. So it's why in the low-income countries, we don't have an exact number of how many cases were there.
Thank you very much. I will let Dr. Vulani continue and introduce the next speaker, please. He needs to be unmuted.
Okay, thank you. Yeah, so the next, I'm Bruce Vulani from Zambia. The next presentation is by Hannah Thompson, and she looks at the performance of a new model for the simulation of gastroschisis cord-side silo application. This is via reduction and suture disclosure in an interventional study. This should be interesting to hear, as gastroschisis is a big problem in this part of the world, and we're seeking to find ways of reducing the mortality of this condition. Hannah, if you're ready, you can go on with your presentation.
Thank you very much. I'll just share my screen. So thank you very much for the opportunity to present our work. It's an honor to speak to you all. Today, I'm going to present our findings regarding the performance of a new model for the simulation of gastroschisis cot-side silo application, reduction, and sutureless closure in an interventional study. Gastroschisis is one of the more common congenital anomalies that we treat as pediatric surgeons, but each of the rural healthcare centers across the continent may not see that many. Therefore, it may be difficult for the multidisciplinary team of professionals caring for these babies to get adequate exposure to them to develop the confidence and competence in management strategies. We need repeated encounters to progress up the learning curve. In 2015, the Global Burden of Disease study reported that congenital anomalies have risen to become the 5th leading cause of death in the under 5s globally. Some of the latest estimates from low and middle income countries indicate that gastroschisis has an incidence of almost 1 in 2,000 live births. So we would expect 16,000 new cases of gastroschisis per year, with a mortality in low and middle income countries of around 76%. The management of these conditions needs increasing priority. Preformed silo utilization may be critical in the reduction of gastroschisis mortality in low and middle income countries. They don't require anesthetic and can be applied at the bedside by any trained healthcare professional. So how can we train people to apply preformed silos? We think that simulation training is an excellent option. Simulation training is a well-established way to facilitate acquisition of procedure-specific skills and refine technique. Several previous simulation models existed for gastroschisis, but with many issues. One previous model that we have used in the past used sausages to simulate the bowel. The disadvantages of this includes religious and cultural insensitivities, scarcity of the resource, particularly in rural areas, and it being unhygienic. This model didn't allow the simulation of skin closure or of umbilical manipulation and has very low fidelity, and it was time consuming to assemble, dissuading from frequent use. Other higher fidelity models have been created, but cost over $1,300 each. As a group of pediatric surgeons, we collaborated with a medical model specialist to design and produce a new model. Here, we describe the performance of the new model in a multi-center interventional study. So let me introduce you to the GABI-T model for gastroschisis and all its new features. This model has non-biologic silicon bowel, improved fidelity, and the ability to simulate all steps of the preformed silo use and gastroschisis care. There are two versions of the model, one with matted bowel, seen here on the right, and one with unmatted bowel, shown on the left. We made this model for $390 US per model. This series of photographs shows the model being used for all stages of silo reduction and sutureless closure. We made a series of tutorial videos to demonstrate the appropriate it being used for silo application. Here you can see a sped up version of the video. These models were used to demonstrate protocolized care for babies with gastroschisis that was being introduced as part of an interventional study in 7 different pediatric surgery centers and 30 referral hospitals across sub-Saharan Africa. We recorded the effectiveness and durability of the models. Using this model during the study, we found we were able to effectively simulate nasogastric tube insertion, application of oxygen SATS monitors, application of nasal cannulae, rectal washouts, preformed silo application, reduction of the bowel, and sutureless closure of the defect using the umbilical cord. 16 GABI-T models were used to teach preformed silo application, 2 for each of the 7 centers and 2 as extra teaching aids. Each model was used approximately 100 times. 5 of the models sustained minor bowel tears, which did not affect the performance. 1 model had an unintentional area of thinner silicon within the abdominal wall, resulting in a small tear. In 3 of the 16 models, the umbilical cord became detached from the abdominal wall, although the risk of this can be reduced by awareness and care. 1 model, which was used significantly more than others, sustained more significant bowel tears. The latter 4 models required replacement cords and bowel, respectively, at a cost of $265 US per model. As Professor Hadley reminded us in the opening lecture, pediatric surgery is a team event. In all, around 2,000 healthcare providers were trained, including midwives, obstetricians, nurses, neonatal and pediatric doctors, pediatric surgical teams, and allied healthcare professionals. Using the model, they were all taught the relevant components of care according to their role. Each study center retained 2 models, one with unmatted bowel and one with matted bowel, to enable the sustained training, teaching of new team members, and refresher sessions. Local teams subsequently used their models to provide simulation sessions at international conferences, increasing the awareness and skills of the wider surgical community. In the future, we hope that this model can be used to support the rollout of gastroschisis interventional packages of care to improve mortality in other centers and in other parts of the world. To conclude, this model has high fidelity and reasonable durability at moderate cost, and has revolutionized the training of high volumes of healthcare providers. I've included a series of links here for further information. This is the contact detail for our provider of the preformed silos, and here you can find links to the gastroschisis care protocols and a link to the library of tutorial videos. We'd like to thank all the people listed here for their valued contribution and extend a sincere thank you to all the gastroschisis study team members. We'd also like to thank the study funders, the Wellcome Trust and the Royal College of Surgeons England and King's Centre for Global Health. And thank you all for listening.
I don't see my colleague, Dr. Vulani on. Maybe there's a connection problem. I'll thank you very much for an excellent presentation, Hannah. And again, staying very well on time. We do have 3 minutes, and there's a frantic chat room debate about some of the things that you're describing. Not so much about the models, as much about the whole idea of what's important in low and middle income countries, and the importance of the silo compared to the entire process of care. The questions are whether, one comment by Professor El-Halabi, was that the problem is availability and resources at NICUs. It's not a reduction in the abdominal defect closure. Would you like to sort of comment on that from the gastroschisis study perspective?
Yeah, absolutely. So we know that one of the big problems with these babies is the condition in which they reach the tertiary center. So they often come profoundly septic and dehydrated. And that is obviously a really important part of the care protocol. And those are elements that are really carefully addressed in the interventional study protocol that was implemented. And obviously that will sort of be a really important sort of factor going forwards. What we're really sharing here is showing how we can simulate the silo application once we've got to that point of the protocol. And in this sort of vein of trying to upskill perhaps non-surgeons, you know, this is something that can be done by nurses, by doctors in rural centers, by clinical officers. So it's really about trying to, well, it's certainly another method that can be used to task shift, but we need a way to teach those people how to use the silos if we are going to have successful care of gastroschisis. So it's absolutely a very, very important question, and I hope that goes some way to answering it.
Thank you. I'm not sure if Naomi is on right now, because it is interesting. There's also a comment. Obviously, not everyone is aware of the fact that we do have preformed silos available now for LMIC at very, very reasonable costs. If Naomi is not on, maybe we can, Hannah, can you mention about the availability now of several actually companies of very inexpensive silos?
Yeah. So we have got a particular provider who's providing them at a cost of approximately $14.5, and I've included the contact details of them there. So that's kind of how that's what we've been using. So once those sort of silos are available and become increasingly more widely available, then obviously that's a point where these teaching models become even more useful, because whilst all the peripheral, you know, all the sort of resuscitation and TPN is important, actually being able to get the bowel back into the abdomen is fundamental to the care of these babies. So once we've kind of got the resources and the skills to do that, then only then can we reduce the mortality.
Thank you. Thank you very much. Maybe we'll ask you, Hannah, to just put some of the information in terms of availability, and maybe Naomi when she's back on the chat group, and we'll move on now to the next presentation, which is goes to a different area of the body and different part of the continent. This is regarding thoracoscopic T2-3 versus T4 sympathectomy for primary pulmonary hyperhidrosis in children and adolescents, a randomized comparative study, which will be presented by Ismail El-Halabi.
Good afternoon, everybody. Good afternoon, Dr. Dan. I hope you're all doing
Yes, we can hear you.
Okay, I'll start sharing my screen now.
Perfect.
Okay, it's obvious now, isn't it?
Yeah.
Okay, so the topic of this presentation will be about thoracoscopic T2 and T3 versus T4 sympathectomy for primary pulmonary hyperhidrosis in children and adolescents, which was done as a randomized comparative study. As we all know, hyperhidrosis is defined as excessive perspiration beyond the physiological needs. These excessive amounts of perspiration and sweating, which can occur in the palms and the axillae and the feet, cause significant psychological, social, and occupational inconvenience. There are several systemic and topical treatments available. Not all of them have proven to be quite effective. Yet, sympathectomy itself has emerged as an treatment for such severe cases or cases which are not responding to the medical treatment. Thoracoscopic sympathectomy, after its introduction, has become the mainstay for treatment in severe cases because it's minimally invasive and it has low rates of morbidity and also post-operative mortality. Then comes the very hot topic about the proper level of sympathectomy to perform, as there's a controversy existing the proper level. Throughout history, it has been found that T2 and T3, and in addition to T4 as well, they produce resolution of the pulmonary symptoms, yet they are different in results when it comes to the patient satisfactions and some of the post-operative side effects and complications. From here, we started to do our project, which was to evaluate the T2 and T3 versus T4 sympathectomy in the management of primary pulmonary hyperhidrosis in the children and adolescents. And we had 32 patients in this study, which expanded during 1 year. They were divided into 2 groups by closed envelope system. Group 1 included 18 patients who underwent T2, T3 thoracoscopic sympathectomy, and group 2 included 14 patients. For these patients, for the 18 patients in the group 1, 14 of them had the procedure bilaterally done, and 4 of them had only unilateral thoracoscopic sympathectomy, in a total number of procedure of 32. And in group 2, the 14 patients were 11 of them had the procedure bilaterally, and 3 of them had it only on one side, with a total number of procedure of 25. So the whole number of procedures in this study was 57 procedures. This is the age distribution of the patients. As we can see, it expanded from the age of 5 years to 18 years of age. The majority of cases were between 11 years and 18 years of age, with comparable age group in both group 1 and group 2. Also, the percentage of males to females was almost equal, 17 males and 15 females, also comparable in both groups, group 1 and group 2. Age at first presentation is the age at which the child or the family and the parents began to complain of the onsets of such sweating. It expands from the age of 4 years to 12 years in this study. And as we can see, the majority of children in this study actually sustained their very first symptoms below the age of 10 years. And then there's the site of hyperhidrosis. All of the people the people in the study group, the adolescent and children, they had sweating of their hands and feet, but around 50% also had sweating of the axillae. People were in this study were placed in like severity groups. They would have like moderate or severe symptoms according to some manifestations, which is how much the problem affects their social life and the amount of dribbling they have from their hands and so on. And they were found to be either having moderate or severe degrees. Also, these degrees were comparable in both groups, group 1 and group 2. Patients were asked to assess their quality of life preoperatively in a score from 1 to 5. 1 is very poor, 5 is excellent. And it has been found that out of the 32 patients, 22 patients, which is like 70% of the people, 70% of the children, they rated their quality of life to be very poor. They have problem socializing, they have problems using instruments, they have problem writing, they are being sometimes bullied by their friends, which is a major thing to think about. 7 patients rated as poor, 2 rated as good, 1 patient rated very good, none of the patients rated excellent. This is a pie chart showing the previously described ratings. And then we use the database entry form, which is adopted from one of the works of our colleagues in the US when it comes to assessment of the quality of life. We used this database entry form to collect some of the data preoperatively, as well as assessment of the quality of life regarding functionality, social area, interactions, and some other things. This is also one of the examples that we have used. We use these charts to place the data of the patients pre and post-operatively as well. Then we will start to talk about the surgical technique. There are a lot of ways to perform the procedure, a lot of ways to position the patient. We actually prefer to use this semi-fowler position or the semi-sitting position, and the patient will be a little bit tilted to the other side. And here's the site of the trocars that we have used as being seen here on the photos as A and B. A is the 5th space mid-axillary line, and the B is the 4th space anterior axillary line. We use the A port for the camera and the B port for the working instrument. We normally used only 2 ports. We didn't have to use any additional port in any of the cases. That's the view of the thoracic cavity once we enter on the right side. As you can see, the sympathetic chain is extending along the necks of the rib from upward, downward. And then there are like intercostal veins. If we go downward a little bit and we move the lung, we can see the azygos vein. The superior vena cava is also obvious at the upper part. And the left side is quite similar, but there's also difference when it comes to the subclavian artery, which is present here. The heart is actually more obvious. That's why the left side is kind of a little bit trickier than the right side. Surgical technique was about performing cutting of the pleura on either side of the sympathetic chain, and then we will get access to the sympathetic chain itself, as we can see in the upcoming video. That's a video which was performed on the left side of T4 thoracoscopic sympathectomy. That's T2, T3, and T4. We are coming straight to T4 right now, identifying the chain, which is at the neck of the rib. We will produce by the hook some heat on either side of the chain, dissecting the pleura that's covering the upper surface of the chain. Note that we are using heat in short bursts. We don't use it in continuous fashion to avoid any injury or anything. The chain has become more obvious now. We will start to hook the chain from upward, from the down surface, going upward and downward. Here the chain is very clear. We will start cutting using low heat setting as well, upward and downward. And then the chain will be cut. Easy as that. Sometimes we'll perform some short heat bursts to cut any remnant nerve tissue. So as I said before, there were 32 patients. However, 7 of them undergone the procedure on only one side. Normally we perform the procedure sequentially, meaning that we start by the dominant hand, and then after a few months we would go for the other hand. But 7 out of the 32 preferred to undergo the procedure only on one side, because 5 of them were satisfied by the result. They didn't feel like they would go to the performing the next side, and 2 patients lost follow-up after 3 months. In this group of 7 patients, no compulsory sweating was noticed in any of them.
I will ask you to please start wrapping up your presentation.
Okay. So about the groups, there is group 1 and group 2, and the operative time was quite comparable. Regarding post-operative outcome, post-operative dryness was more common in group 1 than in group 2. Compulsory sweating was more common actually also in group 1 than in group 2. Horner syndrome occurred in 1 case in group 1, which didn't occur in group 2 at all. There was no recurrence of hand sweating. This is a picture of the aesthetic outcome. Patients were followed up by chest X-ray 6 hours post-operatively, and then they were followed up for the next month in the clinic. Patients were also asked to rate their quality of life post-operatively. 25 patients of the 32 rated excellent quality of life, 5 rated very good, 2 patients lost follow-up. And a second questionnaire was taken, and as you can see in the table here, there is significant difference between the pre-operative and post-operative evaluation. However, it's more favorable in the group 2, which is a T4 sympathectomy. So to summarize, the T2, T3, and T4, both of them are safe and effective treatment for hyperhidrosis. However, it was found that post-operative compensatory hyperhidrosis is quite more common in T2 and T3, yet with no statistical difference. Unilateral sympathectomy performed in some patients didn't show any compensatory hyperhidrosis, which needs to be investigated in a larger group of patients. And the hand-over dryness occurred in T2 and T3 group. It didn't occur in T4 group. Slight moisture of the hand occurred in T4 group, and this didn't occur in any of the T2, T3 group. And this moisture of the hand was quite tolerated by the patients. And due to the proof of efficacy of both approaches, and because of the more patient satisfaction in the T4 group, we prefer to use it rather than the T2, T3 thoracoscopic sympathectomy for pulmonary hyperhidrosis. I would like to thank you very much. I thank the ePAPSA board for giving me the chance for this presentation. And I wish to receive any questions.
Thank you very much. I don't think that the time is available for that. There are some questions, and we will ask you can see on the chat box, and you can answer those directly to the, or even to everyone based on that. Thank you very much. I'll pass the podium back to Dr. Vulani to introduce the next speaker.
If you can please ask, if I may ask Dr. El Halabi to stop
Hello?
sharing.
Hello. Yep. Thank you for that enlightening presentation. The next two presentations on aneurysmal malformations, and the first one will be aneurysmal malformation, earlier the diagnosis, better the outcome, by Nelish Tank. And I'll invite Nelish Tank to come on and give her presentation. Is Nelish Tank available?
Available, he's sharing.
Okay, thank you.
Am I audible?
Yes.
Yeah, yes, you are. Thank you. You can go ahead.
Thank you so much.
Remember, you have 10 minutes.
First of all, I would like to thank the organizers for giving me this opportunity to speak on this platform. I'm a pediatric surgeon from India. As a pediatric surgeon, we are quite familiar with this title. The earlier the diagnosis, and the better is the outcome. My talk is on very simple topic, but the information is very useful. Well, we all know that the aneurysmal malformations can have very good prognosis, especially the intermediate and the low variety, if they are diagnosed at a proper time after the birth. For that, we need to have proper perineal examinations. And if we miss the diagnosis after the birth, then this baby would present to us very lately at the higher center. So ultimately, this delayed diagnosis and the presentation would lead to increased pre, peri, and post-operative complications, and ultimately the outcome would be affected. That was the aim of our study, to compare the presenting characteristic and the outcome of early versus delayed presentation of these ARM patients. It's a prospective study for 1 year, and those patients who presented within 48 hours after the birth were placed in group A, and those who presented after 48 hours were placed in group B. Congenital heart disease itself has a very important impact on the outcome of these vector malformations, so irrespective of the type of the ARM, irrespective of the timing of the presentations. So we have excluded this congenital heart disease from our study just to reduce the bias on the mortality part. Quite a few variables were recorded during the study, like gestational age, the birth weight, weight on the arrival, breastfeeding attempts, the place of the delivery at the time of admissions. Then on clinical examinations, abdominal distensions, mild, moderate to severe variety. We took blood culture on the arrival at the hospitals. The patients required quite a few hours for the resuscitation, and whether they have required any inotropes during the preoperative preparations. Types of the ARM and the operative procedure performed were also recorded. And after the surgery, how much time the stomach required to function, to initiate the first feed and to reach on the full feeds. And in post-operative period, how many patients had bone infection because of the delayed diagnosis, and the overall hospital length of the stay and the mortality. So we had 28 patients in group A and 26 patients in group B. Well, the important thing that I want to highlight here is that in group B patients, they have significant weight loss. If you compare the birth weight and the weight on the arrival, the group B patients had lost significant weight, and this value is quite statistically significant. So if there's significant weight loss at the time of arrival, then these babies might have poor prognosis. Obviously, these group B patients had more number of breastfeeding attempts because of the delayed diagnosis. 5 of them were delivered at home, but surprisingly, quite a few patients were born at the primary health center, community health center, even at the tertiary health center. They were missed after the birth with the diagnosis of the ARM, and they presented to us very lately. The abdominal distension was quite severe in the delayed group of the patients, and the p-value is quite significant. Like in this picture, if we can see that the skin of the abdomen is really shiny, that it is tense and distended, and the overall the hemodynamic condition is not good in these patients, and ultimately it affects the overall outcome. The blood culture was positive in quite a few patients in group B as compared to group A. because this patient presented to us very lately, so the hemodynamic condition was not good. So we required more hours for the resuscitations, and 5 out of 26% also required the inotropic support. These values are quite significant if you compare with the group A. And one patient died preoperatively during the resuscitations. Now, this shows the various types of the ARM and the procedure performed in group A and group B. The point I want to highlight here is normally in low ARM, we do anoplasty or anorectoplasty. That is a single stage procedure. But because this patient presented to us very lately and the condition was not good, there was undergoing enterocolitis, and one of the baby had perforation. So rather than providing the anoplasty or anorectoplasty, we had to divert by doing the stoma. So HDHC was performed in 3 out of 4 patients. So this delayed diagnosis can also affect the procedure that we are going to operate on these patients. The single stage procedure can become 3-stage procedures. Because of the hemodynamic condition was not good, because the bowel condition was not good in group B patients, there was enterocolitis and undergoing infections. So these patients required more time for the stoma to function after the surgical corrections and to initiate the first feed. And to reach on the full feed, they also required more number of days as compared to the group A patients, and these are quite statistical significance. Wound infection was also almost in 50% of patients in group B patients. Out of 12, 2 patients had actually the wound dehiscence. These are quite common in group B patients with a delayed diagnosis, with the poor nutrition, poor immunity, and the overall poor hemodynamic status. The length of the stay was also higher in group B patients. 4 out of 26, 15% of the mortality we had in postoperative period during, after the postoperative care in this group B patients, which is also quite shocking. To summarize, if there is significant weight loss, if you compare with the birth weight and the weight on the arrival, it's an important prognostic factor. It will affect the overall outcome of these patients. The delayed group had high preoperative complications like dehydration, shock, sepsis, enterocolitis, perforations, and they required more time for the resuscitations. The post and perioperative complications like changing in the procedure to be performed. Single stage can become 3-stage procedures. They require more time for the stoma to function, to initiate the first feed and the reach on the full feeds, more of wound infections, and the overall mortality. The main thing that we want to highlight here is, in countries like India, where the 80% of the delivery are conducted at the primary health center and the community health center by the medical and the paramedical staff, nurse, or the midwives. We need to train this the medical staff who are working at the PHC and the CHC, because if they are not very well trained in the perineal examinations, they might miss these ARM patients, and then this baby would be discharged to the home and then would be fed multiple times, and they would come to us in a very bad situations. And then ultimately, instead of providing the best of surgical care, we would not be able to, give them a good prognosis. So this is the take-home message from our study. Along with this ARM study, we also did the same study on tracheoesophageal fistula. Earlier the diagnosis and the better the results. And we also found the similar kind of, the post-operative outcome in that particular study. So we need to really train our medical and the paramedical staff who are working at the PHC and the CHC to have the early diagnosis and the best the overall the outcome. Thank you so much. Thank you so much.
Okay, thank you very much, Nilesh. A very good presentation and highlighting some of the problems that we have in this part of the world, in Africa. We have time for perhaps 2 or 3 questions. If there any questions that anyone would like to raise before we go on to the next talk. I see one question from Kokila here, or is it a comment? In a national BAPS CAS study in the UK showed that 85% of ARMs were missed at birth, which is interesting because that's a part of the world where you expect that this kind of thing shouldn't happen. But you've already, Nilesh, you've already outlined that it is important that medical staff should be trained carefully to look at these newborn babies to see if they have any congenital abnormalities. Are there any other questions? I don't see any other questions. I think we'll then move on to the next presentation, and this will be from Amir A. Abduzed, and this will be on anorectum of anomalies in the female, highlights on the surgical management. This should be an interesting talk to hear. Amir, you can go ahead and with your presentation.
Yes, thank you very much. My presentation is about surgical management of anorectal anomalies in the female. Anorectal anomalies is characterized by different clinical presentation in both sexes with consequently different management protocols. There are several controversies and different strategies to manage anorectal anomalies in the female. Here we would like to present our experience in managing girls with anorectal anomalies, highlighting the rationale behind the chosen protocol. The study included 121 girls with anorectal anomalies who underwent sagittal anorectoplasty during the last 10 years. Their age ranged from 3 months to 5 years. The study included cases with rectoperineal fistula, 68 cases, rectovestibular fistula, 51 cases, and 1 case with rectovaginal and another case with imperforate anus without fistula. As you can see, we have excluded cases of cloacal anomalies to be presented in a separate study. Almost all cases underwent a delayed primary repair. Here, cases where primary repair means without covering colostomy, and we delayed cases beyond the age of 3 months. Cases were managed by laxatives and dilatation of the rectal fistula till the time of definitive surgery. Only 5 cases in this out of the 121 girls underwent preoperative colostomy, 2 cases for rectovaginal and the other without fistula, and 3 cases underwent colostomy in the neonatal period before referral to our facility. We applied the same technique, anterior sagittal anorectoplasty, for both rectoperineal and rectovestibular fistula. The patient is placed in the lysotomy position. To go quickly through the operative details, the racket-shaped incision and incision of the striated sphincter complex behind the fistula. This is an important step, complete incision of the sphincter to form a space to accommodate the mobilized anorectum. Otherwise, under correction and residual anterior displacement will result. Also, we start the dissection at the posterior and lateral aspects of the anorectum. Even we go for suprafistular dissection, leaving the difficult separation of the distal rectum from the vagina to be performed at the end. We need to stress that a sufficient length of mobilized anorectum is important for both rectoperineal as well as rectovestibular fistula. This is very important to avoid tension at the anocutaneous anastomosis, which may be the cause of anal retraction and wound complications. The anus anorectum is placed in its predestined location, and reconstruction of the perineal muscles anteriorly. Regarding the early complications, we had 14 cases, making 11% post-operative wound complications that were more common among rectoperineal group. This case, no wound complications. Here's a skin disruption in the skin, perineal skin, and sparing the anocutaneous anastomosis. This is another case, also perineal skin disruption, extending to the 12 o'clock position. Again, effective mobilization of the anal retraction even with wound complications. Delayed healing problems in the form of mucosal prolapse or ectropion. Here is a case good cosmetic result. Again, this is very good, and only we can see the mucosa upon skin retraction. And here we can see the excess mucosa on one side, which will need to be excised. 34 cases were available for the delayed functional assessment, and we had voluntary bowel control in 90% of cases. Among the 3 cases who failed to achieve voluntary bowel control, one of them had generalized developmental delay, while sacral dysplasia was detected in another case. Constipation was detected in 20%, while fecal soiling was present in 6 cases. 3 of them who failed to achieve bowel control, and 3 other cases were associated with constipation. Through the literature, we tried to pick up some controversial and debatable questions. Maybe the first question, whether to do primary versus staged repair, either to do a protective colostomy or no colostomy. Many centers from different parts of the world have reported the feasibility of performing primary repairs without colostomy for rectoperineal and rectovestibular fistulae. However, the major wound disruption with anal retraction may represent a series of postoperative complications that may necessitate a rescue colostomy. Fortunately, we had a low incidence of major disruption, only 4 cases. All of them could be attributed to suboptimal anorectal mobilizations for cases of rectoperineal fistula performed during the early years of the study. The second question, if you will perform a primary repair, whether to do it in the neonatal period or a delayed repair. And it's quite rare for these types of anomalies to present with acute obstruction or enterocolitis similar to Hirschsprung disease. The site of rectal termination is usually amenable for dilatation, and in this study, we always delayed the repair after 3 months of age. This was well tolerated, and by this approach, we have gained dual benefit, avoiding the high risk of operating during the neonatal period, as well as sparing limited places in the NICU for more critical neonatal surgical situations. Lastly, whether to perform muscle splitting versus sphincter sparing techniques. We all know the transsphincteric approach introduced by Dr. Pena and Duvier has much improved the outcomes in cases of anorectal anomalies. However, recent reports claim the need to improve continence potential by returning to sphincter sparing techniques. Actually, we cannot find very good reason for that, because most centers have reported good voluntary bowel control in their case series, and moreover, fecal soiling in these cases have been greatly attributed to constipation, which we believe might be aggravated by revisiting the sphincter sparing techniques. To come to a conclusion, delayed primary repair for rectoperineal and rectovestibular fistula is feasible with low complications. By adopting this protocol of management, we could achieve comparable results while avoiding unnecessary operations during the neonatal period. Thank you very much for your attention. And for those who are interested, they can visit and have the access to the full text online. Thank you very much.
Okay. Thank you, Amir. Very interesting presentation. And I think as you were presenting, one of the questions which was going through my mind, which I think a number of us would have wanted you to answer, which you did in the end, was the difference between transsphincteric and suprasphincteric approach. But you did explain that, as far as you know, excising the sphincter gives a better, it seems to give a better outcome. I know quite a number of us would prefer to avoid the sphincter if we can leave it undamaged during a procedure like this. I don't know what the approach of many others in the house is, but generally that's the approach that we have taken, like at our center. But sometimes, quite a number of times, you tend to still damage the sphincter, and you have to repair it anyway. That is a common thing. Are there any questions? Maybe one or two before we close the session, or before I hand over to Dan. I hear a comment here saying muscle sparing is a good option, and I think that's basically my feeling as well. But I know this is debatable. There's a question here which says, from Marion Arnold in South Africa, it says, do you use bowel prep in your delayed primary repair? So maybe Amir, you can just tell us something about that.
Yes, the child is hospitalized 48 hours, fluid diet and enemas. Fluid diet 24 hours before operation, and enemas, saline enemas.
Okay. Okay. When you say fluid diet, what do you mean? I mean, is it clear fluids?
Yes, clear fluids. Clear fluids for 24 hours.
All right. Okay. Thank you. And then Arnold also asks, and how long do you give antibiotics post-operatively?
Yeah, it's 48 hours post-operative, and we start feeding. There are several debatable questions also when to resume feeding, oral feeding. Some centers say it's the first day post-operative, others wait for about 7 or 10 days. Actually, we take 3 days post-operative because we have noticed that skin complications usually occur between the 3rd and 5th day. So we inspect the wound on the 3rd day, and if everything is okay, we start feeding on the 3rd post-operative day. And antibiotics for 2 days, only for 2 days.
Okay, I'll just, before I hand over to Dan, I'll just ask one more question, which Bip from Malawi asks, any advice to anyone, to someone who is used to a 3-stage when they're considering how to begin to do a single-stage procedure?
Yes,
is there any advice you can give to?
Yes. The advice is the effect of the extent of mobilization. You cannot move the anal canal without moving the rectum. So you have to mobilize the rectum. We had you may think that the rectoperineal fistula will need less dissection than the rectovestibular fistula, but actually we do the same degree of dissection. So when you have a good mobilization in the proper plane, this will decrease wound complications. Even if you have a post-operative wound complications, it will not be associated with anal retraction, and that it's the fear you have anal retraction, and here you will need to go for a colostomy. So it's the anorectal mobilization.
Okay, thank you. Okay, thank you very much, Amir. I'll have to stop you there and hand you over to and hand us back to Dan, and then he will continue from there. Thank you.
Thank you very much.
That was an excellent discussion. Pediatric surgeons love anorectal malformations. So I'm glad we had that discussion. Just before we finish, there was one presenter earlier today who was not able, for technical reasons, to complete her presentation, Dr. Nemanja Stella Alice, and we'll give her the opportunity now to do that. Her talk was on implementing online teaching format led by pediatric surgery fellows in Uganda due to COVID-19 educational disruptions, an interim report. Please go ahead.
Thank you very much. My apologies to everyone for the technical issues that I had. So just in the interest of time, I'll pick up right from where I left off. So basically, like I was saying, COSEXA has given us a platform to train surgeons right at home, which is really good in terms of cost effectiveness and in terms of retention of surgeons from home. But Global Surgery has also provided a platform for international collaborations. So these homegrown surgeons are actually able to pick up skills and expertise that they wouldn't have if they had stayed at home. The pediatric surgical team in Uganda has 2 training sites for the pediatric surgery fellowship program that are about 268 kilometers apart. So trainees rarely ever get in touch except for the camps that happen once a while. Now, global health partnerships have boosted the local faculty on ground. The small numbers have been boosted with international faculty that are available to both training sites, Mbara and Mulago, at different times throughout the year. So previously, an online teaching format was designed by the faculty with case-based scenarios that were usually posted on email, and fellows were given 2 weeks to submit their answers, which eventually faculty would then respond after the deadline had been met. However, after 6 or 5 sessions, it eventually dwindled down. And I'm guessing my opinion would be due to the demands that faculty had and the time lag, 2 weeks and 3 weeks. So many would forget when they were due to reply to the responses or when they were supposed to post a case. So then a mock-like clinical exam teaching format was then adopted, as opposed to the usual PowerPoint presentation or the didactic lectures by the faculty. So this was done in person, and usually this was when the international faculty was present. So active case scenarios were given with a timing given for to prepare the fellows who are just about to sit exams, especially the senior fellows. Now, the problem is COVID-19 disrupted surgical education across sub-Saharan Africa. And with the lockdowns and the cancellation of elective cases and closing of OPDs, this really took a huge hit on us. So with the absence of international travel, the partners were also affected due to travel bans, and it decreased the interaction that the African teams had with international faculty. So of particular concern were the fellows who were supposed to sit their exams in just a few months' time before the lockdown went down. So our aim for this was just to create an online-based teaching due to the pandemic. And how we did this was we had a 1.5 hour Zoom-based conference every 2 weeks, which was planned by the Ugandan fellows, but coordinated by both faculty, Ugandan and international, covering most of the core topics in pediatric surgery. Each session was usually facilitated, alternating by Ugandan and international faculty. So a case-based format was agreed upon rather than the didactic lectures, and Ugandan fellows usually presented 2 cases per session, followed by an oral board type of discussion format, so like a Q&A. And support for internet data for the trainees was provided by the international collaborations. So this slide is just an example of the case scenarios that the fellows usually will present. These were actual patients that were on the ward or had been on the ward previously. So lots of pictures and lots of videos were used to kind of create a real feel of the patient being right in front of us. So the results is we created a 1-year schedule, and this was coordinated by the faculty. So far, 10 teaching sessions have been completed, and these have covered core topics in pediatric surgery. Fellow participation has been 100%, and faculty facilitation has alternated between Ugandan and international faculty, with about 4 to 6 faculty present for teaching sessions, which has also been good because on so many occasions, it's always been 1 faculty present. Now we have about 4 or 6 at a sitting. This is just an example of the topics that have been covered so far, pediatric surgery topics. So this format has allowed joint teaching between the 2 training sites, which previously had not had any joint teaching sessions. But it's also allowed for exchange of local and international practice patterns in many areas of clinical controversy. Considering we're in different settings, it's allowed for that exchange. It's also offered a platform to share ideas on the active management of some of the cases that are presented, as the theoretical skills that are discussed are later on translated into real practical solutions. This hasn't come without its challenges. One is the different time zones, as many as 10 hours apart. So how we've dealt with this is kind of keeping the schedule flexible, especially for the international faculty to see when and where would be convenient for them. And yes, internet connectivity, the network on and off, like I kind of had issues before. So this is kind of like an ongoing thing. So in conclusion, the pandemic has created challenges to surgical education worldwide. But in this case, it's also spurred the creation of an online interactive teaching session that has been well attended. These sessions have allowed for ongoing exchange of information and skills transfer despite the travel bans and the lockdowns. And considering that now the future seems to be online, virtually, even for examinations, this is kind of in a way helping us gain confidence to the new way that examinations are kind of going to go, both clinical and written. Thank you.
Thanks very much for a very nice presentation and keeping very well on time. In fact, we do have time to discuss this a bit, and I'll be looking for questions. I think my immediate comment is that this pandemic has forced us in so many ways to decide if we will find new ways and accept new ways of doing the same things we've done for decades or not. And this very meeting that's happening on Zoom is an example of the fact that unless we change, we will not survive. And certainly surgical residents have done that with Zoom meetings. And in fact, the entire world has found that we can do a lot of the things that we did through very expensive and lengthy travel, simply using electronic platforms. So thank you for bringing that perspective. There is a comment here that they do have a very similar experience in Sudan, probably for the surgical residents. Are there any questions, verbal questions? Anybody is like to comment on this? Maybe from the educational committee, those involved with the educational committee of PAPSA, if there is any comment in terms of how we will continue to foster this various remote education processes through our organization, would be very, very valuable. If not, yes, there is a couple of comments. This is a lesson that COVID has taught us. And a question, yes, educators from high-income countries may not understand presentations and management in our environment. Do you have any guidelines? This is to Stella. Do you have any guidelines on how to help this? In other words, how to help high-income country presenters contextualize their talks to the context, to the African context? Stella?
Yeah, so basically, like I'd said, most of what we've been doing has been led by we, the fellows, us that are locally on ground. So as we present the cases and we talk about how we're able to manage them, I think this basically gives them an idea of what's on ground and how we're doing things. So that kind of gives them a way to contextualize it. I don't know if that makes sense. It's led by the fellows, it's led by us, and not usually by the high-income country faculty. So I guess that's what helps.
That's excellent. I appreciate the taking over of control to where it needs to stay on the site. Thank you. I think we will wrap up with this. We'll wrap up this free paper session. Thank you for all the presenters. It was very interesting, and again, it just reminds us that we are pediatric surgeons, whether through COVID or not, and we continue to improve how we perform our pediatric surgery. I will pass the podium back to Professor Imanoglu now.
Thank you very much, then. As a very famous person said one day shortly after the Second World War, never let a good crisis go to waste. And I think that's exactly what we have done in the last 2 days. We still have one more short poster session, and I would encourage colleagues to remain with us. There's some very good posters, and Mahmoud will be sharing them with us very shortly. So while he's preparing it, certainly the last 2 days has been great, and we've discussed a lot about COVID-19, certainly. And a year ago, we wouldn't be able to think about having an online meeting, and we were preparing to go to Bruce's place. And I'm sorry we couldn't come and see you, Bruce, Day, but we will definitely do it in 2 years' time, certainly. And COVID-19 has taught us a lot of things. So we heard a lot about the de-escalation during COVID-19 and how difficult it was from our side, certainly the re-escalation was perhaps even more difficult to bring everything back to not the normal, but the new normal. And what we are seeing now is what we have learned from COVID-19 and what we're going to be taking further from here. The session around the pediatric surgical conditions just reminded us that we are all pediatric surgeons, and COVID will perhaps it's come and it's going, but we're going to be remaining with our pediatric surgical topics, and it's wonderful, and it's so nice to hear them again, and certainly the presentations were of very high quality. So while in the background perhaps the posters are running, I just would like to thank every one of you who attended this meeting. Without your participation, without our delegates, this meeting wouldn't have been possible to have. And we really appreciated all of you spending your Friday afternoon and Saturday afternoon with us. It's something that we'll certainly have in the future as well. I would like to especially thank to our invited speakers and to all the oral and poster presenters. Again, thank you so much for contributing to that. The Executive Committee of PAPSA has been having a lot of discussions how to run and how to create such a environment like this to share the scientific content. And I'd like to thank every one of our Executive Committee members putting a lot of effort and time and energy into it and bringing this together. They also acted as the scientific committee, and Francis Huber has volunteered to lead the scientific committee, and with the contribution of all the colleagues, a tremendous amount of work has been done to get to this point, and very much thanks to every one of you. Mahmoud Al-Fiki from Egypt helped us with the technical aspects, and Mahmoud, if you can just put it onto slideshow for us and we can see the posters at the same time. Thank you very much. And also to Omar Kamak. Omar is a registrar in pediatric surgery in Cape Town here, and without his help, I don't think we would be able to run such a smooth online meeting. Well, he's a good pediatric surgeon. I don't want him to take up an IT job after this meeting. Please remain in pediatric surgery, Omar, but we appreciate all you have done for the meeting too. So next year, we will be having another online meeting. So we will communicate the details with you, and it's going to be hopefully improved and better one than what we had this year. And if you have any comments and suggestions, and you're more than welcome to send them to us through the WhatsApp group that Soji has established about 2 years ago, and we will take note of them, and we'll try to incorporate your suggestions into the meeting next year. And perhaps, as we have just heard from our last speaker as well, a lot of things can be done online. We don't have to have a formal meeting as such that we're having to continue our collaboration, and it's really very important for colleagues who are based in our continent to continue communicating with each other and to continue advancing pediatric surgery in our continent. And we are the ones really who can take pediatric surgery further in Africa. We are the ones have to be doing it, and we have the ability to do it. And by collaboration and communication, we can certainly achieve our goals. So thank you very much to every one of you. It was lovely to have you all online and have the opportunity to share things. And we look forward to further meetings and further engagements with you in due course. And have a lovely evening and have a wonderful weekend going ahead. We will keep the meeting on for a little longer for the posters to be shared and viewed. We'll keep the chat line on. The physical meetings are fantastic to do networking, and people said that perhaps online meetings won't have that opportunity, but what I can see from the chat box, we are starting to network also online. So use the chat box, share information, network with each other, and stay in touch. Thank you very much to everybody.